So in our last video or in our last discussion, we kind of laid down the foundation for the treatment for bronchial asthma, as you can already see on the screen. So in this discussion, what we are about to do is we are going to delve into the details about the individual approaches for treating bronchial asthma. In this discussion, we will primarily focus on bronchodilators. Okay, so this discussion will be about bronchodilators. So we will be talking about bronchodilators as in the autonomic nervous system ones and methylxanthines. So we will talk about the adrenergic or the beta 2 sympathomimetics and the M3 anticholinergics as well as methylxanthines, because these three are more or less the directly acting bronchodilators, whereas the others, corticosteroids, leukotriene antagonists, mast cell stabilizers or the antigen antibody reaction inhibitors, these bring about, obviously finally they bring about bronchodilation, because that's the entire reason why you're treating these drugs or why you're giving the drugs to the patient, because bronchoconstriction is the primary ailment in asthma. But they are not directly causing bronchodilation, they are causing something which is indirectly causing bronchodilation. For example, corticosteroids over here. We'll talk about corticosteroids in detail in the next discussion, but just to exemplify what I'm talking about really, corticosteroids, as I had mentioned, steroids, they actually kind of inhibit phospholipase A2, which would in turn inhibit the entire prostaglandins and leukotriene synthesis. Now prostaglandins, leukotrienes, these are incredibly powerful mediators of inflammation. Thus, steroids are the drug of choice for any kind of inflammatory reaction in the body, right? So any kind of swelling or any inflammatory reaction you're seeing, wounds, steroids are very much preferred, right? So, and since asthma is a type 1 hypersensitivity reaction, it's an inflammatory response, that's why steroids come in handy. But they are not causing bronchodilation directly, right? Whereas the others, they are causing bronchodilation, the beta 2 sympathomimetics, the M3 anticholinergics, methylxanthines. So in this discussion, we will limit ourselves to talking about what I just said, the bronchodilators. Okay. Now, in our discussion about bronchodilators, that is the drugs which bring about bronchodilation, we have to understand that autonomic nervous system plays a very, very big role here. Okay. So, the autonomic nervous system, again, this is something that I had mentioned before. It is that part of our nervous system which is dealing with all those involuntary functions and actions, right? So bronchoconstriction, bronchodilation is an involuntary function, and hence autonomic nervous system has a large role to play in it, right? Right. Now we know autonomic nervous system, again, it's actually having two branches, the sympathetic and the parasympathetic. This is just a recap, actually, very short recap for anyone who has not watched the previous videos. So sympathetic, what would the sympathetic nervous system do as far as bronchodilation or constriction is concerned? Sympathetic nervous system would bring about bronchodilation. Why or how you remember that? Because sympathetic nervous system is only sympathetic, which means it only positively stimulates the heart. It increases the contractility, it increases the force of contraction, the heart rate, etc. For all other major organs, it will down-regulate, it will cause relaxation. So, alveoli, bronchioles, they will relax, the muscles will relax, the walls will relax, so bronchodilation. Whereas parasympathetic would cause bronchoconstriction. Right. So if I can provide a drug which actively stimulates the sympathetic nervous system in the lungs, in the bronchioles, in the alveoli. That is, a drug which will agonize the sympathetic receptors in the lungs, or a drug which will actively antagonize the parasympathetic receptors in the lungs. Both will cause bronchodilation. That is the idea behind bronchodilatory effect brought about by autonomic nervous system drugs. So, if we are to go under the sympathetic system first, the sympathetic system, let's talk about the drugs. First of all, I had mentioned in my previous introductory video of the autonomic nervous system that sympathetic system has majorly alpha and beta receptors. Excuse me. So majorly it has these two types of receptors, which are alpha and beta. What kind of receptors are present on the lungs? The answer is we have beta 2 receptors. How you remember this is by the fact that 2 means 2 lungs. So beta 2 is present in the lungs. Whereas if I am to say beta 1, only one heart. So beta 1 is present in the heart. So this is kind of a neat little trick for remembering the where the receptors are present. Now a word of caution here. Beta 1 is present not only in the heart but in some other regions as well, and beta 2 is present not only in the lungs but is present in a lot of other regions as well. In fact, beta 1 is actually more or less heart, it's more or less related to heart, but beta 2 is not only in the lungs, it's present almost everywhere in the body. Okay, so beta 2 is kind of like M3 for parasympathetic. Parasympathetic muscarinic receptors, we had M1, 2, 3, right? So we would talk about this in the parasympathetic system. Right now we are dealing with the sympathetic system. But M3 receptors, they are kind of present everywhere, all major organs. Beta 2 is also like that. Anyways, this is not that important. So beta 2 receptors, the beta 2 sympathetic or beta 2 adrenergic receptors, beta 2 adrenergic receptors, the drugs which will positively stimulate this, they would cause bronchodilation, and these drugs are known as sympatho, from the word sympathetic, sympathomimetic drugs. Sympathomimetic drugs. Mime means to mimic. Sympathetic mimicking drugs. So the drugs which would mimic the sympathetic system. Okay, pretty self-explanatory. What are these drugs? Now we come to the names of these drugs. So let's write it down. Beta 2 sympathomimetics. Okay, what are they? Let's go with what can we go with? Let's go with green. That's a good color. So these are the names of the drugs. What are they? Salbutamol, number 1. Okay, then okay, let's not write that one now. Let's write terbutaline, then salmeterol, and then formoterol. So these are more or less the names of the drugs which are beta 2 sympathomimetics. Okay. Now obviously these are names, and names are, well, they aren't logical, so we have to memorize these names. But there are a few, tricks, which I wouldn't say actually tricks, I wouldn't even say mnemonic. What I do for remembering these names, let me tell you that. Okay, so listen to me very carefully. See, have you heard of the name of that show? Better Call Saul. It's a very popular show, right? So I just actually kind of remember this in my head. Instead of Saul, I actually remember it as Better Call Sal. Better Call Sal. So Sal, 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 Sal. And I kind of, try to recall that actor's face. I've forgotten the name of the actor. I think his name is Bob something. I might be wrong actually. Bob something, I guess, maybe. The actor who plays Saul in Breaking Bad, or even Better Call Saul, that show. Or Nobody, that film. Anyways, I really do hope that you have watched at least one of these shows or the film, or you know what I'm talking about. Otherwise it's purely for nothing. But that's kind of like how I remember. I try to remember the face of that actor, Bob Odenkirk or something like that, I think his name is. Better Call Sal. I try to remember it like that. Better Call Sal. Sal what? Salbutamol, salmeterol. And for meterol, I kind of try to remember a metro. So I kind of try to remember salmeterol, this name. I remember it by the actor Bob Odenkirk, I think his name is. I might be wrong. The actor, he is standing in a metro station. In a metro. So salmeterol. Okay. While the actor who plays Saul, but I am calling him Sal, is standing in the metro, hence salmeterol, there comes a turbulence. There comes a turbulence. So turbulence means terbutaline. Also you have to remember that this is not the spelling. Turbulence is TU, but this is TER. But they sound obviously similar, completely similar. So while Sal is standing in a metro, Sal, you can remember salbutamol, salmeterol, there comes a turbulence, turbutaline. Okay. And the last one, I just remember it. The last one, really, I don't have any mnemonic for it. I just remember formoterol. I don't have a mnemonic for remembering this. So this is clearly more or less how I remember. Also, another thing is salmeterol has meterol in the name, right? And formoterol also has that meterol. So that is one thing that you can remember. Now, before going into the details of each of these drugs, actually, you know what? Let's go into the details of each of these drugs. There isn't much to talk about each of these drugs individually, but there are a few points. There are a few interesting points about each. So let's start with salbutamol. So salbutamol, obviously, as you can see, it's a beta-2 sympathomimetic. Now you need to understand something here. Salbutamol is also known as albuterol. Albuterol. So terol, meterol, formoterol, salmeterol, albuterol. So terol is kind of in the name of salbutamol as well, because salbutamol is also known as albuterol. Now I'm not that skeptical about alternate names that much, but what really struck me interesting is, and I don't know whether this is a trend or not, when I was studying this book called First Aid, I don't know if you have read it. It's for people who aspire, who prepare to give the USMLE exam. It's basically for the American hospital cares and all that. So there, instead of salbutamol, the name was albuterol, and I could not understand what albuterol was. Then I kind of opened my actual pharmacology book, and then I found out that okay, albuterol is also the other name for salbutamol. So these are some regional things that, you know, I don't know whether this is a big deal or not, but just because I kind of learned it a little hard way, so I like to emphasize on it. So what are some of the interesting things about salbutamol? Firstly, it's a very highly selective beta-2 sympathomimetic or a beta-2 agonist. Okay, it's highly selective. Okay, now since it's a drug which is affecting the respiratory system, so how would you like to administer the drug? Would you like to take salbutamol pills? Would you like to take salbutamol intravenously, intramuscularly? Or for day-to-day use, would you like salbutamol in the inhalational route? Yes, the answer is very simple. It's taken via the inhalational route. Inhalational route. But the thing is, the other routes are also possible. That is, salbutamol tablets are also kind of available, and salbutamol can also be given intravenously. Intravenous, obviously, we give when it's very acute case of asthma, and we immediately need to, in a hospital setup obviously, we immediately need to relieve the patient. Then intravenous can be given, but otherwise inhalational route via a metered dose inhaler, MDI, metered dose inhaler, that's actually given. Okay. Now another thing, and this is the most important thing about not only salbutamol but some of the other beta-2 sympathomimetic drugs as well, is that salbutamol and some others as well is a short-acting drug. It's a short-acting drug. What does that mean? It means that once you take salbutamol, it would start working within 5 minutes, kind of within 5 minutes, but its effect lasts not much, up to about 2 to 4 hours. So it has a faster onset of action, but it is short acting, right? And this is the major reason why salbutamol is used for acute asthma episodes. So it's not used for chronic cases where the patient chronically has asthma episodes, or it's a seasonal thing, or it's a COPD. No, it's used for very acute asthma episodes where immediately some action is needed. So when immediate action is needed, obviously you need a faster onset drug which would immediately start acting, and we do not much care about the about how long it would last, because our primary focus, our concern would be to relieve the patient for that time being. So salbutamol is a very, very important drug of choice. DOC, drug of choice for acute asthma cases or acute asthma episodes. Okay. So since this is the drug of choice for acute asthma episodes, what are the side effects of salbutamol? Because there are side effects. Side effects. We write side effects like this. Side effects is, and this is something that would recur in beta 2 sympathomimetic drugs, is principally something that we call tremors. Tremors. And the reason for this would be clearer when we study the autonomic nervous system, when we study about the adrenergic drugs in detail. Actually, muscle tremors, they are kind of stimulated by the sympathetic system, right? So tremors is a very important, or the most important rather, dose related side effect for salbutamol. Others can also be there. For example, nervousness might be there, then some kind of restlessness might be there, some irritation might be there, throat irritation might be there, and some kind of hypokalemia is also sometimes seen. Okay. Hypokalemia is also seen sometimes. But tremors, they are the most important dose related side effect for salbutamol. Okay, muscle tremor. Now these are more or less the most selective points about salbutamol. Let's go to terbutaline. Now terbutaline, there isn't much to talk about terbutaline. Salbutamol and terbutaline, they are more or less very similar. Okay, they are more or less very similar. But there is something to be said about salbutamol and terbutaline combined together. What is that? Salbutamol and terbutaline, both of these, they are short acting drugs. They are short acting. Whereas salmeterol and formoterol, they are long acting. Also, another thing, since we are kind of on the list itself and we can just get it out of our way, within salmeterol and formoterol, formoterol starts with an F. So that means that formoterol is the faster onset. It has a faster onset than salmeterol. Salmeterol starts with an S, so it has a slower onset. Slower onset. So out of salmeterol and formoterol, formoterol has a faster onset and is long acting. Whereas salmeterol, it is having a slower onset but it is long acting. Whereas salbutamol and terbutaline, they are comparatively short acting. But once all of these we have discussed, we would come to know that beta 2 sympathomimetics overall is reserved for acute cases, acute asthma cases. So beta 2 sympathomimetics, although we have some beta 2 sympathomimetics which are like salmeterol, formoterol, they are long acting, like 24 hours they can go, 12 to 24 hours they can go. But even then, we do not much use them for chronic cases. For chronic cases, we have much better drugs which we would study later. Beta-2 sympathomimetics overall, salbutamol, terbutaline, salmeterol, formoterol, these are more or less reserved for acute asthma cases. Okay. Now, having said that, some more points about the salbutamol and terbutaline. See, a very important, I would say, precaution, you might say, regarding the beta-2 sympathomimetics is that they should not be used on a daily basis. A very important, this is a very important precaution that we need to take. Salbutamol, terbutaline, these are short acting, very fast onset, and they can be used for acute cases of asthma. But they should not be used on a daily basis, on a prophylactic basis. Prophylaxis. No, not for prophylactic uses. Why? Because interestingly, it has been seen that these drugs, they kind of not only do they not improve the bronchial hyperreactivity, but they actually kind of worsen the bronchial hyperreactivity. So these drugs have been found to worsen the bronchial hyperreactivity. Okay, so they kind of worsen the situation, and what happens is, what this translates to is the fact that within a few years the patient develops kind of an immunity, or the patient actually develops some kind of hyporesponsiveness to these. So then these drugs would not work on the patient, right? So that is why they should only be used for symptomatic relief and not on a prophylactic basis, because they worsen the bronchial hyperreactivity, and thus, since they worsen it with time, so within a few years the patient would develop hyporesponsiveness, that is, the patient, he or she would not respond. So acute cases would not be we would not be able to treat acute cases in that patient with these drugs, if the patient is a chronic user of beta-2 sympathomimetics. So these drugs should be only for occasional episodic asthma cases, acute asthma cases, symptomatic relief. Okay. So that's more or less, I guess, everything about the beta-2 sympathomimetics. Now, as far as the doses are concerned, I'm actually not that interested, or I do not find doses to be that important. I guess we would study doses in internal medicine later, but then again, I guess it's cool to know the doses. So salbutamol is, since it's is the most important asthma drug, so I guess it's better to know the dose. So we actually use salbutamol in like 100 to 200 microgram inhalational route. So it's like 2 puffs, I think. In a pressurized metered dose inhaler, you take 2 puffs and you're good to go. Terbutaline, it actually needs a little more. It's like 250 microgram inhalational route, obviously. Okay. The rest, I don't think they're that important as far as the doses are concerned. Formoterol, it actually acts for 12 hours when inhaled. As I said, it is a long-acting drug, 12 hours when inhaled. And obviously, it has a faster onset of action, like I mentioned. Whereas salmeterol, it is a longer acting, but it's slower onset. Okay. So that's more or less everything important about the beta 2 sympathomimetics. Now, since we are on the topic of autonomic nervous system, let's quickly delve on the other branch of the autonomic nervous system. That is, let's now talk about the anticholinergic drugs. So, let's talk about the anticholinergic drugs. That is, the drugs which are M3 antagonists, the muscarinic M3 blockers. Now, under this category, we have only two drugs, the most important two drugs. That is, okay, did I write them with white or okay, green? I use green and I use white for that. Anyways, let's use yellow for this, I guess. So one of them is ipratropium bromide. Ipratropium bromide, and the other is a similar sounding tiotropium bromide, or I don't know whether it's tiotropium. Yeah, it is tiotropium bromide. Yeah, tiotropium bromide. Very similar sounding drugs. So ipratropium and tiotropium bromide. Okay. So now for remembering this, I have absolutely no mnemonic because these names are so unique kind of names. Ipratropium, tiotropium. So it kind of really there is no mnemonic for this. I've kind of recalled it. I've kind of memorized it. Anyways, so these are the two M3 blockers. Okay. So what exactly is happening? See, I said that parasympathetic system, it brings about the bronchoconstriction. So M3 receptors, they are actually present in the lungs, in the respiratory tract, right? So if we can antagonize them, if we can block those receptors, then we can cause bronchodilation and hence we can treat asthma. But the thing about both ipratropium and tiotropium bromide, although tiotropium is, let me write it down, tiotropium, it is actually it's a long acting drug, whereas ipratropium is a shorter acting drug. It's a longer acting drug. Anyways, but the thing about both ipratropium and tiotropium is that they are both slow onset. So this is the major difference between the sympathomimetics and the anticholinergics. Sympathomimetics, they are very fast, more or less. We have slower acting beta 2 sympathomimetics like salmeterol, but more or less that's why they are the drug of choice for acute episodic asthma. Whereas anticholinergic M3 blockers, ipratropium bromide, tiotropium bromide, they have a slow onset. Okay, so that's why we cannot use them for patients who are currently wheezing, having dyspnea, who need immediate relief from the asthma episode. We cannot use an anticholinergic then. We would need to use salbutamol. So then what exactly do we need anticholinergic drugs for? We need them for majorly a condition called COPD. Chronic obstructive pulmonary disease, COPD. So what happens in COPD? COPD is not actually synonymous to asthma, although they are both having some similarities. But COPD, as the name suggests, is chronic. But what happens in COPD is, COPD deals with actually majorly emphysema, that is alveolar destruction. And what happens is, the bronchioles, they would lose their elasticity, so bronchiolar fibrosis occurs. And a very major thing that happens in COPD is the expiratory airway hindrance or expiratory airway limitation, which means, let me write it down first and then I'll explain to you. Expiratory airway limitation. This means that during expiration, when a person is breathing out, there is a premature closing of the alveoli, which causes shortness of breath. So people who have COPD, they find it very hard to do anything which requires a little physical activity. So they get tired very easily because they have obstruction in their expiratory airway limitation. And this is because of chronic abuse of the airway. So that is why COPD is very common in chronic smokers. We see emphysematous alveolar destruction, bronchiolar fibrosis, where the bronchioles kind of lose their smooth elasticity, right? So in COPD cases, the anticholinergic M3 antagonists, they are very useful. They are very, very useful, right? Why is that? The reason is, it has been seen that in COPD, this bronchiolar loss of elasticity, that can actually be kind of reversed by these anticholinergic drugs. Okay, so the inhaled anticholinergics, they are the bronchodilators of choice in COPD. Okay, so let me write it down. The inhaled, these anticholinergic drugs, they are the drug of choice for, or drug of choice or bronchodilators of choice for COPD. Because COPD is a chronic case, it's not acute. So you acutely do not need some kind of a treatment, you do not need relief. Chronically it has been happening. So chronically you need something which is longer acting. That is why tiotropium bromide, it is preferred over ipratropium bromide. Even in between the anticholinergic drugs, tiotropium is the more preferred one. Okay. So obviously, if we combine the anticholinergic, so the M3 anticholinergic, if we combine that with the beta-2 sympathomimetic, that would actually lead to even more increased bronchodilation, because their effects are additive, synergistic. And that is why majorly, and this is something that we would see in our clinical practice as well, for treating asthma, majorly in chronic cases, we often give a combination of drugs. We never actually give a single drug. We often try to exploit the disease or to treat the disease rather from different avenues. So we give beta 2 sympathomimetics for some episodes or for symptomatic relief, and along with that we also give some long acting things which would actually enhance the sympathomimetic drugs. So in this case it can be anticholinergics, it can be some kind of corticosteroids, inhalatory corticosteroids, it can be antileukotrienes, right? So this is a very powerful combination. So for example, salbutamol and ipratropium, they are combined in many formulations. For example, duolin inhaler, they are combined, salbutamol and ipratropium bromide, and that actually leads to an additive effect as far as the bronchodilatory efficacy is concerned, right? So COPD major treatment is by anticholinergics, because as I mentioned, the reflex cholinergic tone, that appears to be the major reversible component of airway obstruction in COPD. In COPD, that reversible, it is reversible actually, the cholinergic tone, that is actually reversible, and that is why anticholinergics, they are the way to go. So not much to say over here other than that. Next we move on to the last directly acting, I would say, bronchodilators, that is the methylxanthines. Now the thing about methylxanthines is, let's go with green, methylxanthine. Okay, so methylxanthines, they are actually a class of compounds, they are a group of compounds. Okay, what exactly are the compounds? There are three major compounds, three major chemicals which are falling under the methylxanthine category. They are, number one, caffeine. Caffeine, is that the spelling? Yeah, it is. Number two, theophylline, and number three, theobromine. Okay, out of these three, caffeine and theophylline, they are the important ones. Theobromine, it has no therapeutic importance. Out of caffeine and theophylline, since we are talking about respiratory pharmacology, it is theophylline which has major bronchodilatory properties, not caffeine. Caffeine does not have bronchodilation effect as much as theophylline does. But both caffeine and theophylline, they are what we say to be CNS stimulants. So both of them kind of they increase alertness, wakefulness, they increase skeletal muscle contractility, they increase focus, decrease tiredness, right? And as far as their effects on the heart, CVS, is concerned, both caffeine and theophylline, we are actually, see, our scope of discussion in over this video is respiratory pharmacology, right? But before going on to the major respiratory function of theophylline, because caffeine does not have any respiratory bronchodilatory effect, that is majorly theophylline. Before going into that, we are kind of giving a very short note kind of a thing, a very short discussion on methylxanthines in general as far as their other systemic properties are concerned. So CNS stimulants, they increase the skeletal muscle contractility. In the CVS section, this is a little weird. They increase directly acting, they actually kind of increase heart rate and contractility, etc. directly, but they also kind of stimulate something called the vagus nerve. Now vagus, if you have some idea, you would know that vagus nerve stimulation would mean that it is a parasympathetic nerve. So parasympathetic system has what kind of effect on heart? It would decrease the heart rate, the force of contraction, etc. So this one is increasing when directly acting and decreasing also. So net effect, what is the net effect then? Net effect is, it has been found that caffeine actually has a decreased heart rate effect, bradycardia, whereas theophylline, that kind of increases the heart rate. So it all depends on which methylxanthine compound has which effect, or rather which methylxanthine compound has more marked effect. So it has been seen probably that caffeine is decreasing heart rate, which means that caffeine stimulates the vagus more than its direct action on the heart, whereas theophylline has a more direct action on the heart than its vagus stimulation, right? So this is more or less the major functions of methylxanthines other than their respiratory function. Now let's move on to the actual scope of our discussion, which is the respiratory part, their action on lungs. Now when I say there, I actually mean to say theophylline, because caffeine does not have much effect. So what is the effect of theophylline? Theophylline. See, theophylline, as we are talking about bronchodilators, it's no surprise that theophylline is a very potent bronchodilator. But that would not be enough. We have to delve a little, just a little bit, on the mechanism of action. Okay. How is theophylline actually bringing about bronchodilation? And by the way, when we will be talking about the mechanism of action of theophylline, indirectly we would also be talking about the mechanism of action of the beta 2 sympathomimetics, because both actually have I wouldn't say the same mechanism of action, but indirectly they have very similar mechanism of action. Let me explain. So what theophylline does is, it has major two functions. Number one, okay, let's go with the white one now. Number one is that it is a phosphodiesterase inhibitor. And number two is that it blocks adenosine receptors. These are the two most important functions of theophylline which brings about bronchodilation. How so? See, we have ATP in our cells. ATP is converted to cyclic AMP by adenylyl cyclase. Adenylyl cyclase. or if it is GTP, then it would be cyclic GMP, guanylyl cyclase. Now this cyclic AMP, it is actually, you might say, metabolized in a way by an enzyme called phosphodiesterase, PDE, phosphodiesterase, to 5-AMP. And if it is cyclic GMP, then 5-GMP. Okay. What theophylline does, theophylline would inhibit this step. It would inhibit the phosphodiesterase. What would that mean? What does that mean? That means that cyclic AMP levels would start skyrocketing. So, and this is what actually matters, this is the statement that would count. Cyclic AMP has been found to be a very potent bronchodilator. This statement counts. This is the statement that makes all of this other steps, all of this other knowledge worth it, because now that you know cyclic AMP is a bronchodilator, we would know that cyclic AMP levels increase in theophylline action. How that increases? We do not let the cyclic AMP degrade or be metabolized. How was it being degraded or metabolized? By an enzyme called phosphodiesterase. So theophylline is a phosphodiesterase inhibitor. So this is how you work it back to the mechanism of action. Now, another way is that it blocks adenosine receptors. Now, adenosine is kind of a mediator of a lot of functions in CNS, CVS, right? So what blocking adenosine receptors would mean is that, see, adenosine, it's a very potent bronchoconstrictor. So this is another very important piece of information. Adenosine is a very potent bronchoconstrictor. It is also actually a potent, I think it's also a very potent vasoconstrictor as well. It's actually a vasoconstrictor, but I think it dilates the blood vessels in the cerebrum. So it dilates cerebral blood vessels. Anyways, that's not our point of concern over here. Our point of concern is that adenosine is a very potent bronchoconstrictor, right? So if we can inhibit, or if we can antagonize the receptors of adenosine, that would also mean that we are bringing about a reduction in bronchoconstriction. So in these two ways, by blocking adenosine receptors and by phosphodiesterase inhibition, theophylline is bringing about its bronchodilatory effect. Now, when I had mentioned about the salbutamol or salmeterol, the sympathomimetic drugs also lead to an increase in cyclic AMP level in the mast cells and other inflammatory cells, right? So this is something that I had forgotten to mention over here. These beta 2 sympathomimetics, they also kind of increase the cyclic AMP level. Details would be kind of discussed when we talk about the actual autonomic nervous system pharmacology. They also increase cyclic AMP level, and thus in a similar way they also bring about bronchodilation, just like theophylline, right? Theophylline, I had mentioned another thing, that theophylline or caffeine also, it also actually increases the skeletal muscle contractility. Although this is not really related to what we are discussing right now, but I guess it wouldn't hurt to know a little more. So theophylline has another action, which is increase in skeletal muscle contractility. How it does that? It actually leads to the release of calcium from the sarcoplasmic reticulum, Oh no, this is smooth endoplasmic reticulum. Actually it is smooth, but sarcoplasmic reticulum, let's not confuse things over here. from the sarcoplasmic reticulum, okay, in the skeletal and the cardiac muscles. And if we know that this would lead to increase in contractility in the skeletal muscles, right. So these are the main three actions of theophylline. Our major concern was the phosphodiesterase inhibition and the adenosine receptor blocker, okay. That is why theophylline is a very important drug. But theophylline again has a lot of problems. Theophylline is not that fast acting, so theophylline cannot actually be used for the acute cases like salbutamol or salmeterol or formoterol or terbutaline, the beta 2 sympathomimetics. Theophylline cannot be used like those drugs, right. So theophylline is actually again just like the anticholinergics, is used more or less for COPD cases, chronic cases, okay. But even in that also we have better choices than theophylline, and the reason for that is theophylline has a very narrow therapeutic index, therapeutic margin or index, which means this is something that is actually a general pharmacology topic. It means that the safety margin of theophylline is very narrow. It is very easy toxicity. Okay, so easily there is a chance of toxicity for theophylline, and poor tolerability is also another very dangerous thing for theophylline. So theophylline is not a drug which is very safe to use, or does not have much side effects, does not have much adverse effects on us. No, that's not the case. Theophylline easily we can get it can easily reach toxic levels in our bloodstream. That's why theophylline is not that preferred, okay. So that's more or less everything about theophylline, and that is more or less all about the directly bronchodilatory actions or the direct bronchodilators. The remaining drugs, the remaining classes, they bring about some other kind of actions which would indirectly lead to bronchodilation. Obviously the final target is obviously bronchodilation, because that is what we are trying to do in asthma. Along with that bronchodilation, we are also, in chronic cases, we are trying to actually improve the bronchial smooth muscles. We are trying to restore the smoothness, the elasticity of the bronchial smooth muscles and all of that. So that's why in COPD cases we use longer acting prophylactic agents, anticholinergics, steroids, right, so that the anti-inflammatory action can be brought to end, not just a symptomatic release. So those are things that we would talk about in the next discussion. I hope you understood whatever this discussion was about, and I hope to catch you on the flip side. Thank you very much.